Good morning, everyone, or evening, afternoon, wherever you're listening. My name is Kacey, and this is our second podcast episode. The first episode, to recap really quickly, we basically dove into how Dr. Savalia chose plastic surgery as his profession and all the experience that led up to what he is an expert in today, which is breast reconstruction. So I didn't really fully introduce myself. My name is Kacey. I am Dr. Savalia's office manager and surgical consultant. I was originally hired as solely his breast reconstruction surgical consultant. So anybody who walked through the door who had a current or past breast cancer diagnosis of some sort, I was their liaison. So I was in the consult with you when you met with Dr. Savalia. I scheduled your surgery and I answered any pre-op and post-op questions that you had, and I still do that today. Today we're going to talk a little bit about the options that breast cancer patients are given when it comes to breast reconstruction. So obviously there's a lot of options in how you kind of lay out all the options to the patient and what factors you really take into consideration when helping patients choose their options. So let's talk about why understanding your breast reconstruction options, first and foremost, is so important early on in the process of breast cancer, and what does it do to the emotional well-being of the patient?
Yeah, that's a complicated question, and I probably don't have a short answer for it, but I think you have to start off with first recognizing that when you get diagnosed with breast cancer, it's obviously not a planned event. You had a whole life that was happening, and then one day it's completely disrupted by this diagnosis that changes your life forever. And maybe up until that point, you've never even thought about breast cancer, never thought about what your options were. You know nothing about the disease, and you all of a sudden have to become an expert literally overnight. Explore all your options, meet with 15 different doctors, whatever it is, and then make a decision quickly, usually, because it is time critical to be in the operating room and have this taken care of. So when you think about the psychology of the person who's dealing with all that, at that point, they're not thinking about vanity. They're not thinking about what is my breast necessarily going to look like. They're thinking, how am I going to survive this event? Because that's their primary focus. So when they come to me, sometimes they've already decided that they're going to do the most aggressive or radical thing because they want to make sure this never comes back. They want to just take both breasts off. I don't want to see any breast tissue left. I want it all gone. I never want to think about this or deal with this again. And that's the mindset that sometimes people present with. And the challenge is to be able to dial that back and say, let's think about this in a, I don't want to say the word logical, but just in a more factual way, to say, you have this disease, we are going to take care of it. There are many different ways of taking care of the disease that all lead to similar outcomes in terms of survival. So once we can establish that fact and say, you have option 1, 2, 3, 4 to deal with the disease, and they're all valid, then now let's go forward from there and say, what are your reconstructive options once you've made a certain decision? And what will each reconstruction option give you in the end? And I have to help them look forward into the future 2 years, 5 years, 10 years out, because they're only looking three to 6 months out and saying, I just want to get past this and to get back to my life. And I'm going to say, you are going to get past this. You are going to get back to your life. But at some point, you're going to look at yourself in the mirror and see something that, you decided on long ago without perhaps enough information. And so that's what I have to focus on during that initial consultation is, how can I get you to look forward into the future and say, what will I want 5 years from now? Once I feel like I've gotten past this disease, what will I want from my body at that point?
Yeah. And that's really hard to get through to patients. I know I sometimes have to even clarify that point to them. They'll call me and ask me, why did he ask me that question? That's such a aesthetic or a cosmetic question. I'm not here for cosmetic. And they're not understanding that in the future, we want you to be able to look at yourself in the mirror and be happy and feel like yourself and not have to think about this journey that you just went through. And that those type of questions, though, help you get in the patient's head to know what they're going to want. Like one of your questions you ask that I always get asked from patients is, what's your goal size? What bra size are you now? And what's your goal size? And that's just like a routine question for you, but it's a really questionable one for them because they're like, why does he want to know what my goal is? My goal is to just get rid of the breast cancer. So all those kind of questions that you ask help with deciding which option is going to be best for them is what I'm trying to get at.
Right. And it's hard to get all that across in one visit without overwhelming them with information, because this patient has already been to several other doctors before they've seen me. Maybe they've seen a medical oncologist, a breast surgeon, a geneticist. Maybe they spoke to a radiation doctor. They've seen all these other people that have all given them their own bits of information. And when you add it all up, it's an encyclopedia of knowledge. And we all know that when you're in a doctor's office, maybe patients retain 20% of whatever they hear. So I have to try to keep it as simple as possible. But still make it comprehensive enough that they can make a educated decision.
Right. And us being the last doctor usually that they see, and I know when I first meet with them before you come into the room, it's just, you can see the overwhelmed feeling and thoughts in their brain. And it's sad sometimes because you can just see them going through the motions. The breast surgeon's telling them, you got to meet with this person, and they're not being able to comprehend what's happening. They haven't even been able to process that they're diagnosed with breast cancer. And they don't know which option to choose. A lot of the times they come in and they say, I don't know if I'm going to have a mastectomy or a lumpectomy. And then after they meet with you, they're like, oh, easy. I know what I'm going to do now. It's like you're the final. They know what they're going to do after they meet with you. And it's kind of nice because...
Yeah, the key is to establish first and foremost that whether you choose a mastectomy or a lumpectomy is not going to decide your fate.
Right.
For most people. I mean, there are obviously some exceptions to that, but for most people, whether you choose a mastectomy or lumpectomy doesn't decide your fate in terms of cancer, but it does decide your fate in terms of your reconstruction. So you have to be able to look at those options and clearly understand what the outcomes are from each one and then make an educated decision.
Right. And I guess there's some myths to go off of that, and misconceptions, I should say. Some patients will meet with a bunch of breast surgeons, a bunch of plastic surgeons, and there are some breast surgeons who, they're not bad breast surgeons, but they only know and are educated in, you have to have a mastectomy, that's your only option. Is that kind of a misconception, or do some patients just...
I think that was maybe true many years ago.
Okay.
I don't think that's as true now, especially in our community. I think around the country, yes. The key for a breast surgeon is they want to make sure that they not only rid the patient of disease, but make sure they don't end up creating a deformity for a patient. So oftentimes, a breast surgeon in some other area may see a patient with a large area of disease and feel like they don't have a way of removing this disease with just a lumpectomy and not causing a deformity. So then their knee-jerk is to say, you should just have a mastectomy. And at least in our community in Orange County, and specifically at Hoag, where we operate, we have lots of different options that allow breast surgeons to do an aggressive, large lumpectomy. And we come in as plastic surgeons after the fact to reconstruct that breast using whatever tissue is remaining and still have that patient look normal, look good, and have a breast that is aesthetically nice. It's not deformed. So then if you can do that, there is no need for a mastectomy in most cases.
Right.
The end goal is what you choosing a mastectomy for a lot of these women simply because you can't fathom a way to create a nice looking breast out of a lumpectomy.
Yeah. Okay.
Yeah.
And a lot of people also have a misconception that reconstruction is solely for aesthetic purposes. It's kind of true, but
yeah,
it's helping patients at the end of the day.
Well, that goes into the deep-rooted psychology of what is a breast. From a medical perspective, it's a endocrine organ, it's a surface organ, it's you can live without it, but its main purpose is for breastfeeding. But in reality, for humans at least, the breast is much more than that.
Yeah.
It represents femininity. It's tied a lot into your psychology of how you feel about yourself, and the absence of one or the deformation of one can lead to pretty profound psychological impact down the road. So To say that it's purely an aesthetic reason to do a reconstruction is probably not recognizing the deep impact that the breast has on a woman's life in general, beyond its function of breastfeeding.
Yes.
Yeah.
What else do you have to say about choosing options? What advice would you give to a patient when choosing an option?
There's a myriad of options. I usually break it down into 2 categories for people. I say that you can have, well, let's say 3 categories. You can have, in terms of broad categories, you can have a breast conserving operation where you're having a lumpectomy of some sort, and you can combine that with an oncoplastic reconstruction that rearranges breast tissue and allows you to keep your breast. That option is, in my mind, the best option because it preserves sensation. It preserves a breast that is yours. It feels like yours. It is yours. It's just altered a little bit. The alternatives are mastectomy reconstructions. If you have a mastectomy, then I break that down into 2 categories. You can have a mastectomy reconstruction with either implants, or you can have a mastectomy reconstruction using your own tissue from your body, from elsewhere on your body, like from the lower stomach or from the thigh or from the upper back. You can bring tissue into the breast to rebuild the mound of tissue that is missing after a mastectomy. And it will feel soft and feel normal, but it won't really have sensation. So when you have a mastectomy, usually you end up giving up sensation to the breast, which if you have to have a mastectomy, you do it, right? Because you have very few options in that scenario. But if you don't have to have a mastectomy and you're choosing to have a mastectomy because you think it's the more aggressive approach or the better way to treat your cancer, well, recognize you are giving up sensation to your chest, to your breast, to the nipples. And that's a pretty big compromise to make if you didn't have to do it.
Right.
Yeah. So that's kind of how I lay it out for them. And there's obviously far more to go into, but if you can make a decision based off of those facts first, then I try to go into more detail as to each one.
Yeah. Some people also have the mindset, not all patients, but a good amount of patients have the mindset of this reconstruction being like a silver lining. Like if a woman with very large, heavy breasts has breast cancer, now wants to have a lumpectomy, and they're like, well, I've always thought of a breast reduction, now's my opportunity. We had a really young patient, unfortunately, who has to have bilateral mastectomies, and she said, well, I've always wanted a breast augmentation, so here we go. And it's, again, just the psychological part of it. You can kind of look at it in 2 ways, but it is
right. Well, we are the silver lining only often because we're usually the ones not delivering bad news.
Yeah. Yeah.
We're the ones saying, hey, we can help.
We can help.
Right. We'll do something to make this better.
Yeah.
And sometimes, like you said, a woman is in a situation maybe where her breasts have dropped over time. They're larger than she wants. She's always thought about having a lift and a reduction of some sort, but just never found the opportunity. And this is kind of a roundabout way of getting it. And therefore, it can be seen as a silver lining for a lot of people.
Yep.
Yeah.
I do have a question about immediate compared to delayed breast reconstruction.
Okay.
How would you choose that to be an option for a patient? Is it a normal option that you would choose for a patient? What goes into
So immediate versus delayed reconstruction, usually when we're using those terms, we're talking about post-mastectomy reconstruction. So if you're having a mastectomy, the state of the art, assuming it's oncologically appropriate, which in most cases it is, the state of the art is to do an immediate reconstruction. And an immediate reconstruction implies that the mastectomy is being done, and on the same day, you're having at least the initial stage of your reconstruction being performed at the same time. So that when you wake up from surgery, you have something. You have some reconstruction. It may not be complete, but you have something started. And that's the state of the art because it allows you to preserve the envelope of skin, which is all that's remaining after a mastectomy. And when I say preserve, I mean that it doesn't have the opportunity to contract, shrink up, scar down, and stick to the chest. Because if you don't have immediate reconstruction, that's what happens. The mastectomy is done, the skin is laid back down on the chest, everything is sewn up, it's flat, and it scars. And then when you do a delayed reconstruction in that scenario, you're coming back 12 months later, sometime later when everything is healed, trying to now resurrect that skin. And trying to resurrect that skin and be soft and be pliable and be shaped nicely after it's already had a chance to do all the other things I just said, it's much harder, and the results are often not as good. So
the goal is to do it immediate.
The goal is an immediate reconstruction when you can, when it's an opportunity.
So one final question is, do you think that breast surgeons, who are the ones who remove the breast tissue and the disease, how well educated are they in your portion of the surgery, in the plastic surgery side of it, the reconstruction side of it?
Excellent question, and I think it depends on where you are in the country and when your breast surgeon trained, whether they are an SSO certified fellowship trained breast surgeon, or are they kind of the old school general surgeon that trained back in the day in everything and did breast surgery as part of their practice, but was not part of their expertise or their focus, and they just have a general knowledge. So, in the last 20 years, a lot has changed in the landscape of breast surgery. A lot has changed. When I first started, there were no nipple-sparing mastectomies at Hoag, and then all of a sudden there were. And now they're the norm. So a lot has changed in terms of understanding from breast surgeons about breast disease and how to treat it and what we need to do, what we have to do, and what we don't have to do. So at our institution, our breast surgeons are extraordinarily well trained and know a lot of the different options, know all the options that we can offer. But at other places, if they don't know what's possible, then they have to make decisions on what they think is possible. And sometimes, even amongst breast surgeons, there is some knee-jerk to say, you should just have a mastectomy. There's too much disease here, or it's too hard to try to figure this out. Let's just get the disease out and be done with it, because we don't want to waste more time trying to find a different solution. And things like that do happen around the country, but at least they did historically, because I think now there's been a large push from the Breast Surgery Society on education about options, especially about oncoplastic surgery. And that is kind of the hot topic, or the new and up and coming technique and in the Breast Surgical Society. So I think every breast surgeon out there knows what the term is. Maybe they have different levels of understanding of what the term is, but they know what the term is. So I think there's less and less knee-jerk, just get a mastectomy responses from breast surgeons nowadays, and more thoughtfulness about how can we approach this problem in a more elegant way.
That also kind of circles back to what we talked about last episode, which is you being a part of the training program with the fellowship program at Hoag. A lot of the, for instance, one of the breast surgeons you work with now, you kind of had a hand when she was a fellow there, and she now understands a lot more than some breast surgeons do on the plastic surgery side, because you trained her on your side while she was a fellow. Right? So
yes.
That tailors back to your education, your teaching of what you've learned, and that helps them be a better breast surgeon too, right?
Hey, when I started all this, I had no idea where my career was going. I just started doing breast reconstruction. I kind of figured out oncoplastic surgery for myself, thought of new ways of doing things. And the fellows that were rotating through Hoag Hospital would participate in those cases kind of in an informal way in the beginning. And then they saw the value, and they approached their professors at USC and said, hey, we want to work with Dr. Savalia because he's doing all these cool reconstructions, and we want to learn how to do these. So that's when I became a formal part of the faculty. And then now I look back and I'm like, wow, we've trained 50 people. I've had a hand in training 50 people at Hoag Hospital.
It's huge.
And those 50 people are extraordinarily well-trained breast surgeons that have scattered around the country. So the propagation of this knowledge from our little hospital in Newport Beach, from our little practice to go across the country, where now there are centers around the country doing similar things because they were trained here, is astounding. I would never have predicted that's where my career would be.
No, but here we are. Well, basically, to recap, today is all about options. You have options. We're here to help you choose the right option for you and your lifestyle. We take all your your considerations of your life, what you do every day, into helping you make those kind of decisions. Our next episode, we're going to dive deeper into specific cases and talk about how Dr. Savalia treated them, helped them with their breast reconstruction, and their overall outcomes.
Yeah. And I can't wait till we have guest surgeons on too.
I know.
It's going to be amazing.
I know.